Dear colleagues, today we'll discuss medical management, feeding, and care of full-term and premature children. First of all, delivery room care. After delivery, immediate care includes drying the newborn, clearing the airway of secretions, and providing warmth. After birth, most term and late preterm newborns, infant, more than 35 weeks gestation, make a successful transition to extrauterine life and require only routine newborn care. For newborns who are at increased risk of requiring resuscitation, as clinicians skilled in neonatal resuscitation should be present at the time of delivery. The delivery room assessment of the neonate's clinical status is quickly performed by assessing the newborn's gestational age, muscle tone, and respiratory effort. Well-appearing newborns should remain with the mother and be placed skin to skin to promote infant-maternal bonding and early initiation of breastfeeding. Newborns who meet all of the following criteria can be cared for in the normal nursery. Gestational age more than 35 weeks, good muscle tone, and strong respiratory drive, crying and breathing without difficulty. The ABHAR score provides a universally accepted method to assess the status of newborn infant immediately after birth. The score is determined by assessing 5 variables, each of which is assigned a value of 0, 1, or 2. The ABHAR score calculator may be used to determine their score. The following variables are included in the ABHAR score: heart rate, respiratory effort, muscle tone, reflex irritability, and color. The ABHAR score is assessed at 1 or 5 minutes after birth. If the 5-minute score is less than 6, a 10-minute score should be assessed. Approximately 90% of neonates have 5-minute ABHAR scores of 7 to 10 and generally require no further intervention. They can be admitted to the level 1 newborn nursery for routine care, provided they are more than 35 weeks gestation. Infants with 5-minute ABHAR score less than 6 require further evaluation and possible intervention. Approximately 1% of newborns require resuscitation and birth. The transitional period between intrauterine and extrauterine life is during the first 4 to 6 hours after birth. Physiological changes that can occur during the transitional period include decreasing pulmonary vascular resistance with increased blood flow to the lungs, lung expansion with clearance of alveolar fluid, and improved oxygenation, that closure of ductus arteriosus. During this time, the clinical status of newborn should be assessed every 30 to 60 minutes to ensure further investigations and/or evaluations beyond routine care are no longer required for successful transition to extrauterine life. Clinical parameters of the transitional periods are temperature. The normal axillary temperature should be between 36.5 to 37.5 for an infant in an open crib. The normal respiratory rate is 40 to 60 breaths per minute and should be continued after a full minute. Heart rate. The normal heart rate is 120 to 160 beats per minute, but may decrease to 85 to 90 per minute in some term newborns during sleep. Central cyanosis includes cyanosis of lips, tongue, and central trunk. Tone also is important. A newborn should have evaluation performed within 24 hours of birth to identify any abnormalities, for example, birth gyrus, jaundice, signs of sepsis, or cardiopulmonary disorders. This assessment includes review of the maternal, family, and prenatal history and complete examination. Another examination should be performed within 24 hours before discharge from the hospital. Newborn history is very important. Review of this pregnancy, labor, and delivery, including prenatal screening tests and risk factors for sepsis. Then, review of past pregnancies, including a history of congenital anomalies, stillbirths, and/or genetic or syndromic conditions. And review of the mother's and father's medical and genetic history, in particular, maternal illnesses prior to and during pregnancy, such as systemic lupus erythematosus, or pregnancy complications such as gestational diabetes or preeclampsia, maternal medication. Physical examination includes observation of the birth of the infant's general appearance, including his hair, body position and dress, body movement, color, and respiratory efforts, followed by auscultation of the lungs and heart while the infant is lying quietly. Body measurements, weight, length, and head circumference, and vital signs. Examination of individual body parts and organs from head to toes, examination of the hips and spine, which is apt to disturb the infant, usually is performed last. Routine newborn screening tests are administered to all newborns to detect infants who have a serious but potential treatable problem. Rather than providing definitive results, they identify which newborns require further testing. Newborn screening is incorporated into the healthcare system in Ukraine for 21 diseases, including congenital hypothyroidism, congenital adrenal hyperplasia, cystic fibrosis, phenylketonuria. Screening is mandatory for all newborns. It is carried out at 48-72 hours of baby's life and in a maternity hospital or perinatal center. Parents who are against such a check-in can write a refusal. Prevention of gonococcal ophthalmia. In the neonate, the risk of contracting gonococcal conjunctivitis is reduced by prophylactic administration of ophthalmic antibiotics agents shortly after birth. Ocular prophylaxis is safe, easy to administer, and an inexpensive method to prevent sight-threatening gonococcal ophthalmia. In the United States, routine prophylaxis against gonococcal ophthalmia neonatorium with erythromycin ophthalmic ointment is recommended. Silvyl nitrate is effective as a prophylaxis for penicillinase producing Neisseria gonorrhea than erythromycin and should be used in areas where this organism is prevalent. Prophylactic administration of vitamin K. Prophylactic administration is recommended for all newborns to prevent vitamin K deficient bleeding, previously referred to as hemorrhagic disease of the newborn. Vitamin K1 is administered as a single dose given intramuscularly within 6 hours of birth. The dose depends upon the newborn's birth weight. It is important to recognize that vitamin K deficiency bleeding may still develop despite intramuscular administration of vitamin K in neonates with liver disease. Feeding. Newborns should be fed early and frequently to avoid hypoglycemia. Breastfeeding is recommended because of its increased benefits for both the infants and mother compared with formula feeding, except when medically contraindicated. Breastfed infants should be fed as soon as possible after delivery, preferably in their delivery room. Healthy newborns who are fed formula should be offered standard iron-containing infant formula. Healthy newborns are fed on demand, but the duration between feedings should not exceed 4 hours. The volume of feeding should be at least 15 to 30 milliliters per feed during the first few days after birth. Normative growth data for term infants. After birth, infants typically gain 30 grams per day until 3 months of age and 20 grams per day between 3 and 12 months of age. After birth, length increases by 0.75 and 0.5 centimeter per week for the first 3 and following 2 to 3 months respectively. Head circumference increases 0.5 centimeter per week from birth to 3 months of age and then approximately 0.25 centimeter per week. Weight loss. Term newborns may lose up to 10% of their birth weight in the first few days after birth and typically regain their birth weight by 10 to 14 days. Excessive weight loss should be evaluated with a complete feeding assessment, ongoing lactation support, and breastfeeding mothers, and interventions as deemed necessary. Weight loss nomograms based on mode of delivery and for exclusively breastfed infants have been developed. The optimal timing for the first bath is uncertain. Common practice in many birthing centers is to delay bathing for 6 to 24 hours after birth. The rationale of this practice is that it may improve initiation of breastfeeding. However, bathing should be performed soon after delivery if there is clinical concern for transmittable infection exposures. Newborns, infants born to mothers with active herpes simplex virus genital lesion or with a history of HIV or hepatitis B or C In addition, clinicians should be mindful of cultural differences in their perceived need for earlier newborn bathing in attempts to remove the vernix, meconium, or excess blood because of concern of appearance. Definition of prematurity. Preterm birth is defined as birth occurring before 37 completed weeks, less than 259 days of gestation. Degrees of prematurity are typically defined by birth weight or gestational age, BW or GA. Worldwide, the incidence of preterm birth is approximately 10%. It is associated considerable risk of morbidity and mortality, particularly among extremely preterm infants with gestational age less than 28 weeks. Most preterm births occur at 32 to 36 weeks. Approximately 10% occur at 28 to 32 weeks gestational age, and approximately 5% occur at less than 28 weeks gestational age. Birth weight classification. Terminology. Low birth weight, LBW, means that birth weight is less than 2,500 grams. Very low birth weight, VLBW, birth weight less than 1,500 grams. And extremely low birth weight means that birth weight is less than 1 kilo. Gestational age classification. Late preterm infant means that gestational age is between 34 weeks and 37 weeks. Moderate preterm infants means that gestational age is between 32 weeks and 34 weeks. Very preterm infant gestational age less than 32 weeks. And extremely preterm infant is infant with gestational age less than 28 weeks. Pathogenesis for preterm birth. Most preterm deliveries occur spontaneously as a result of either preterm labor or preterm rupture of membranes. The four primary causes that lead to preterm labor and delivery are activation of the maternal or fetal hypothalamic pituitary adrenal axis, infection, residual hemorrhage, and pathological uterine distension. Risk of mortality in preterm infants. Degree of prematurity. The risk increases with decreasing birth weight and gestational age. Sex. The risk is higher in males. Race and ethnicity. The risk is high among Black infants. Congenital anomalies, intrauterine growth restriction, and lower level of neonatal care. Causes of death among preterm infants. Respiratory failure, especially in extremely preterm infants. Infection, congenital anomalies, intraventricular hemorrhage, necrotizing, enterocolitis. Terminology. Neonatal and infant mortality. What is it? Neonatal death is defined as an infant death before 28 days of age. Early neonatal death occur before the first 7 days from birth at the early neonatal period, and the late neonatal deaths occur between 7 and 27 days of age in late neonatal period. Infant death is defined as a live birth that results in death within the first year of life. The infant mortality rate is the number of infant deaths less than 1 year of age during a year divided by the number of live births reported during the same year expressed in 1,000 live births. Complication of infant. Complications of preterm infants with gestational age less than 37 weeks are divided into short-term complications that occur in the neonatal period and long-term sequelae in patients who survive and are discharged from the neonatal intensive care unit. The neonatal period includes first 24 days of life. Complications of prematurity are the underlying reasons for their higher rate of infant mortality and morbidity in preterm infants compared with full-term infants. The risk of complications increases with decreasing of gestational age and birth weight. Short-term complications result from anatomic or functional immaturity during the neonatal period. This complication contributes to the increased risk of long-term disability in this population. Nutrition for the premature infant. Premature infants have greater nutritional needs in the neonatal period than at any other time of their lives. Despite intensive nutritional strategies for premature infants, growth failure remains a major problem. For enterally fed premature infants, their average daily energy requirement are 110 to 130 kilocalories per kilo per day. For parentally fed premature infants, the energy requirements are lower, from 90 to 100 kilocalories per kilo per day for infants with weight less than 1,500 grams because of less fecal energy loss, fewer episodes of cold stress, and somewhat less activity. Introducing and advancing feed. Tube feeding is typically needed for infants weighing less than 1,800 grams and births, usually less than 32 weeks gestation. Trophic feeds are given at 20 milliliters per kilo per day, ideally starting from 6 hours after birth when medically feasible, using mother's own milk or pasteurized donor human milk. Trophic feeds are generally continued for 1 to 3 days before advancing feed volume. Trophic feeds need for stimulation of gastrointestinal tract. Feeding advancement For healthy child, the volume of feeding is commonly advanced by 20 to 30 milliliters per kilo per day. Infants less than 1 kilo birth weight, 30 milliliters per kilo per day in those from 1 kilo to 1.5 kilo, and 30 to 40 milliliters per kilo per day in infants more than 1,500 grams. Target volume for feeds is 160 milliliters per kilo per day or fortified human milk. It is necessary to assess the feeding tolerance. When present, these parameters should prompt the clinicians to evaluate the infants for cause of feeding intolerance and to decide whether to halt feeds temporarily. It's necessary to take into consideration presence of bile or blood, change in stool output and presence of blood, abdominal distension, tenderness, and bowel sounds, increased episodes of apnea and bradycardia, diminished oxygen saturation or lethargy, and emesis, of course. Normative growth data for preterm infants. Weight 15 to 18 grams per kilo per day. Length 1 centimeter per week. Head circumference 0.7 centimeter per week. Hypothermia is an important factor. It is risk factor. Rapid heat loss occurs in preterm infants because of their relatively large body surface area and inability to produce enough heat. Heat is lost by conduction, convection, radiation, and evaporation. In preterm infants, hypothermia is associated with increased mortality, and in survivors, interventricular hemorrhage and pulmonary insufficiency and hemorrhage. Hypothermia may contribute to metabolic disorders such as hypoglycemia or acidosis. Preterm infants are at greatest risk for hypothermia immediately after birth in the delivery room or on admission to neonatal intensive care unit. Risk factors of hypothermia are delivery room temperature less than 25, maternal temperature less than 36 centigrade, lack of heat loss preventive measures. For example, plastic bag, head covering, decreasing birth weight, cesarean delivery, and use of respiratory support with cold air. Prevention of hypothermia, maintaining the delivery room temperature at minimum of 26, drying the baby immediately after birth, removing of any wet blankets, encouraging skin-to-skin contact in healthy, stable neonates, using pre-warmed radiant heaters if resuscitation is necessary. For neonates less than 30 weeks gestational age or 1,500 grams, additional measures used in the delivery room include plastic wraps, caps, and warming mattresses. When transporting preterm neonates, a closed incubator should be used. Once in the neonatal intensive care unit, preterm infants should be carried for in an incubator or radiant warmer, neonates who require advanced respiratory support should receive heated and humidified house mixtures. For neonates with significant hypothermia, rectal temperature less than 35 centigrade, we use a radiant warmer to rapidly correct body temperature. Although slow warming increased less than 0.5 per hour was traditionally their approach to warming infants, data are insufficient to determine if there is an advantage of one approach over the other, rapid versus slow warming. Respiratory complications of maturity are respiratory distress syndrome is caused by surfactant deficiency. The incidence and severity of respiratory distress syndrome increase with decreasing gestational age. Bronchopulmonary dysplasia is a rare respiratory complication that commonly occurs in very low birth weight infants. It is generally defined as an ongoing need for supplemental oxygen and/or respiratory support at either 28 days postnatal age. Apnea of prematurity is a developmental disorder or in preterm infant that is a consequence of immature respiratory control. Other respiratory morbidity include pneumothorax and pulmonary hemorrhage. Pulmonary hemorrhage occurs most commonly in extreme low birth weight infants and may be a consequence of patient ductus arteriosus. Cardiovascular complications in preterm neonate. A patient ductus arteriosus occurs when the ductus arteriosus fails to completely close after delivery. This is common in preterm infants. The patient ductus arteriosus shunts blood flow from left to right, resulting in increased flow through the pulmonary circulation and decreased perfusion of the systemic circulation. Significant shunting may present with apnea, respiratory distress, or heart failure. Cardiac complication in the preterm infant include also low blood pressure, which is common in preterm neonates, especially in extremely preterm neonates. Low birth weight is sometimes associated with clinical signs of poor perfusion shock, and this likely contributes to increased risk of long-term morbidity and mortality. However, many extremely preterm neonates with low birth weight otherwise appear well, and it is unclear whether these neonates are at increased risk for complication. Intraventricular hemorrhage usually increases in frequency with decreasing birth weight. General preventive measures include prompt and appropriate resuscitation. In addition, efforts should be made to avoid hemodynamic instability and conditions that impair cerebral autoregulation, hypoxia, hypercarbia, hypoxia, and hypercarbia. Glucose anomalies. This is example of metabolic complication. Disorders in glucose supply or metabolism can result in hypoglycemia and hyperglycemia. Blood glucose concentration should be monitored routinely, starting within 1 to 2 hours after birth and continued until feeding are well established and glucose values have normalized. Necrotizing enterocolitis occurs in 2 to 10% of very low birth weight infants. It is associated with an increase in mortality. Survivors are at increased risk for growth delay and neurodevelopmental disabilities. In addition, approximately 10% of preterm infants with necrotizing enterocolitis will have long-term gastrointestinal difficulties with persistent loose stool or frequent bowel movement. Infection is also complication of prematurity. Infections as complication of prematurity include bacterial sepsis, fungal infection, particularly candida infections, viral infections, which include cytomegalovirus infection, nosocomial respiratory infection, and other systemic viral infection. Anemia of prematurity. Preterm infants are at high risk of clinically significant anemia because they have lower hemoglobin values at birth compared with term infants, and their postnatal decline in hemoglobin occurs earlier and is more pronounced than the physiological anemia seen in term infants. This is compounded by other factors: blood loss from phlebotomy, reduced red blood cell lifespan, and depleted iron stores. Together, these processes are referred to as anemia of prematurity. Approximately 50% of preterm neonates less than 30 weeks gestational age require at least one transfusion during their neonatal intensive care unit stay. Retinopathy of prematurity is a developmental vascular proliferative disorder that occurs in the incompletely vascularized retina of preterm infants. The incidence and severity of retinopathy of prematurity increase with the decreasing of gestational age or birth weight. The condition typically begins at approximately 34 weeks, although it may be seen as early as 30 to 32 weeks. Patients with severe untreated retinopathy of prematurity are at increased risk for poor ocular income with vision impairment. The next problem is intrauterine growth restriction or retardation. Intrauterine growth restriction refers to the fetus who does not achieve the expected in utero growth potential due to genetic or environmental factors. Clinically, most infants with intrauterine growth retardation are identified because they are born small for gestational age and with birth weight below the 10th percentile for gestational age. Moderate intrauterine growth retardation is defined as birth weight in the 3rd to 10th percentile, and severe intrauterine growth retardation as less than 3rd percentile. Small for gestational age is typically defined by birth weight below the 10th percentile for gestational age. And an alternate definition defines of small gestational age as birth weight for gestational age more than 2 standard deviations below the mean. However, the definition does not make a distinction among small gestational age infants who are constitutionally normally small from those who are growth restricted and small. Constitutionally small infants are those with a normal birth weight below 10th percentile due to constitutional factors including maternal height, weight, ethnicity, and parity. These infants are not at increased risk for perinatal mortality or morbidity. Etiology of intrauterine growth retardation. Nitrogen and protein content are lower because of reduced muscle mass. Glycogen content is decreased in skeletal muscle and liver because of lower fetal plasma glucose and insulin concentration. Fetal growth restriction may be caused by fetal, placental, and maternal factors. However, no underlying etiology is identified in at least 40% of infants with intrauterine growth retardation. In those infants where an underlying cause is identified, intrauterine growth retardation is caused by genetic diseases in approximately 1/3 of infants and is related to the fetal environment in 2/3. Classification of infants with intrauterine growth retardation, symmetric and asymmetric. Symmetric intrauterine growth retardation, infants with symmetric intrauterine growth retardation, 10 to 30% of cases have reduction in all organs and systems with the body, head, and length proportionally affected. Symmetric intrauterine growth retardation begins early in gestation and usually is caused by intrinsic factors such as congenital infections or chromosomal abnormalities. However, decreased nutrient supply, energy in development can restrict growth of all organs. Infants with asymmetric intrauterine growth retardation, 70 to 80% of cases, have disproportionate growth restriction in which head circumference is preserved, length is somewhat affected, and weight is compromised to a greater degree. As a result, the normal-sized head appears relatively large compared with the size of the trunk and extremities. Abnormal growth typically begins in the late second or third trimesters and results from reduction in fetal nutrients that limit glycogen and fat storage, yet allow continued brain growth. Clinical presentation. The infant has the characteristic appearance of an infant with intrauterine growth restriction. Note the loose, peeling skin, decreased subcutaneous tissue and muscles mass, and meconium staining, and the umbilical cord often is thin. The face of severely affected infants has a typical shrunken or wizened appearance. Cranial suture may be widened and the anterior fontanelle is larger than expected due to diminished membranous bone formation. In newborns with asymmetric intrauterine growth retardation, the head appears relatively large compared with the size of the trunk and extremities. The physiology. Intrauterine growth retardation. In intrauterine growth retardation, nutrition supply to the fetus is compromised. The fetus, in order to increase its chance of survival, responds by reducing its overall size, presenting brain growth, accelerating lung maturation, and increasing red blood cells production. The fetus redirected blood flow from less vital organs to the brain, heart, adrenal glands, and placenta. Total body fat, lean mass, and bone mineral content are reduced, resulting in a wasted appearance in infants with severe intrauterine growth retardation. The infant has the typical shrunken or wizened appearance of an infant with intrauterine growth restriction. Antenatal detection of intrauterine growth restriction has increased with a sonographic evaluation of the fetus, placenta, and amniotic fluid. The postnatal diagnosis of fetal growth restriction is most commonly made when the birth weight is below the 10th percentile for gestational age, according to definition of small for gestational age. Gestational age assessment. The most reliable methods are the knowing with certainty the last menstrual period or date of in vitro fertilization and measurement from ultrasound performed before 22 weeks gestation. Gestational age is determined postnatally based on neonatal physical examination and neuromuscular assessment by the Baller scale. Intrauterine growth retardation and prematurity. Fetus with intrauterine growth retardation are at risk for preterm delivery. In some cases, early delivery is performed because the fetal risks of remaining in utero are considered to be greater than those of prematurity. Infants with intrauterine growth retardation who are preterm are at increased risk for death and complication related to prematurity. For example, necrotizing enterocolitis, respiratory distress syndrome, bronchopulmonary dysplasia, and retinopathy of prematurity compared with appropriate for gestational age control infants. Severity affected infant with intrauterine growth retardation may have a difficult transition at delivery with the additional hypoxic stress of intrauterine contraction. This particular an issue for fetus with intrauterine growth retardation due to placental pathology. Impaired placental function results in hypoxia and metabolic acidosis and increase the risk of multiple organ dysfunctions such as hypoxic ischemic encephalopathy, ischemic heart failure, meconium aspiration, persistent pulmonary hypertension, and acute gastrointestinal and kidney injury. Intrauterine growth retarded infants are at risk of hypothermia. Hypothermia is due to the small for gestational age infants' increased heat loss due to reduced subcutaneous fat and reduced heat production due to poor nutrient reserves and depletion of catecholamines. Infants with intrauterine growth retardation should be carried fall in a neutral thermal environment to avoid episodes of hypothermia, e.g., use of an incubator. After delivery, a coordinated response of counter-regulatory hormones and peripheral insensitivity to this hormone may contribute to hypoglycemia in infants with intrauterine growth retardation. Hypoglycemia typically occurs within the first 10 hours after birth. Glucose must be monitored in infants with intrauterine growth retardation because hypoglycemia is common. The risk of hypoglycemia increases with increasing severity of growth restriction that results in decreasing reserves of fat, proteins, and glycogen. Monitoring for hypoglycemia is initiated within 1 to 2 hours after birth. Samples are obtained before feeding. Surveillance is continued in infants with low plasma glucose concentration less than 2.4 millimole per liter until feedings are well established and glucose values have normalized. Polycythemia and hyperviscosity occur more frequently in infants with intrauterine growth retardation, and the risk increases with severity of growth restriction. Increased erythropoietin production resulting from fetal hypoxia is thought to be responsible. A hematocrit, F, or hemoglobin should be obtained in infants who have signs or symptoms that may be due to polycythemia, such as cyanosis, tachypnea, poor feeding, and vomiting. Cellular immunity can be impaired in intrauterine growth retarded infants in the newborn period and through their childhood. In a cross-sectional study, T and B peripheral lymphocytes were decreased at birth. Their lymphocytes number became normal in later childhood, but their proliferative capacity was reduced. Infants with intrauterine growth retardation who are preterm or have birth asphyxia are at risk for early hypocalcemia, which occurs in the first 2 or 3 days after birth. The risk appears to increase with the severity of growth failure. Ionized calcium concentration should be monitored starting at 12 hours after birth, and adequate calcium intake should be provided. Further evaluation and outcome. Further evaluation. Once the infant is stabilized, further evaluation to determine the cause of intrauterine growth retardation should be performed for infants in whom the underlying etiology remains unknown. However, the majority of cases, no underlying cause is identified. Infants with intrauterine growth retardation are at risk for perinatal mortality and significant long-term morbidity, including growth abnormalities and impaired neurodevelopmental outcome. However, there is significant heterogeneity in long-term outcome. In addition, intrauterine growth retardation individuals may be predisposed to cardiovascular disease, hypertension, and chronic kidney disease as adults. Long-term follow-up. Long-term management includes monitoring growth and neurodevelopment outcome, which is typically provided by the primary care provider. So neonatology is very, very important part of pediatrics, and the information about pathology of neonates must be very well studied by students. Thank you for your attention.